This is the RotaPro, and this gives us basically this halo triangle, yellow triangle, gives us an idea that 5,000 rotations have dropped, and more this solid triangle gives you an idea that 10,000 rotations have dropped. So this is a very visually very attractive kind of thing, which is right in front of you, and you can do the procedure seeing that. And the console is also very high tech they have made, and it's really good experience to use RotaPro. So I will take you all through this. Can we have the volume? Can we have the volume of this video?
Line, you can see here there is a drip, and we will just check how much pressure it is generating. This is the gas pressure is there in the console or not. So there is a test called draw test which we do, and which we are going to do. First we see draw means drip. You see here there is a drip coming up. So there is a constant flush is going on, and this is not the rota flush. We have given dilgem and heparin and nitrate, and now we will check the draw means drip, then advancement, and then rotation, and then wire. So these four things we need to check. And here, see here, this is Rotalink Plus. It's not a RotaPro, and this is unlocked and this is locked. So come here, and once it is unlocked, locked, this moves like this. So once we activate, and the rota will show up there. So there, wire is the brake is there tightened. It's important that your brake is there. And then I see here now there will be rotation will happen. And now I see here there's a good movement. So, now you have to fix it 2 centimeters just towards the rota bar, and then you have to go inside.
So the draw test has to be performed beforehand. Before going in, everything is set up, and then you need to do a draw test. You see the drip yourself. That's a line which should be at least 200 millimeter Hg pressure should be there in the pressure bag, so that the drip is continuous, and then it should be advancing freely. There should be no resistance, and it's rotating. You can see the rotational speed there. Here you see here. So once we are testing it, how much speed we are having. So this is 132,000. So we have to increase the speed through this dial.
Okay.
And then now I can appreciate here it's 157. After this preparation, we go in. So without this, you are going in, rushing through the procedure. You are going to not going to do justice to the therapy. So here you see a very calcified LED, and we are going doing rota, and you can appreciate the lesion is not getting crossed here. Everything was getting stuck here, so it is not going in. So we don't have to rush it. We have to go the second run which we started, and then finally we made through. So this is the second run. You can appreciate the rota bar passed, and then there was a followed by polishing run, and then finally we could do, and this was the the lesion, the final stenting. So this is how rotablation is done. So what are important potential complications? How we can avoid that? Recommended maximum drop is 5,000. If you see more than 5,000, it can generate excess heat. It can cause spasm. It can cause increased particle burden. System will stall at 15,000 drop. So be careful. If the sound of the pitch of the sound gets altered, or you see directly that there is a drop in more than 5,000, you have to come back and stop. And always do a slow, smooth, short taking movement rather than forcing the rota down the lesion. Is going to get stuck. So everyone who has done more than 30 rotablation, they have got 1 or 2 stuck bars. So it is not uncommon, but you can avoid after 20-30. If you do next 50, the rota stuck chances will be less, because then we know the nuances. So we don't have to rush through the lesion. If it is not going in, just hitting the lesion and coming down, hitting the lesion and coming, retracting down, and this is how you will go and cross. Do not over tighten the Y adapter. Avoid daughtering. Never stop or start in the lesion or beyond the lesion. You have to stop the rotablation once you are proximal to the lesion. Otherwise, there will be chance of a stuck bar. and never adjust RPMs during ablation. So you can't adjust. You see 180, you don't want to come down 140 while doing putting the foot switch on. So these are all small nuances and tips. You can get 3 feedbacks. One is tactile. I hope I have time, sir. Yeah. So we get 3 kind of feedbacks. One is tactile. So we can get an excessive load on burr or burr advance too rapidly. Then we can assume that there's some problem has happened or can happen. Visual, you can see there how the rota is moving, and auditory pitch changes. So RotaPro, you can see everything in front of your eyes. In RotaLink, you have to see in the console. So you depend more on pitch sound than the visual things. And final polishing run is very important. You should stop when there is no RPM drop, no tactile resistance, good flow through the lesion site and beyond. So, and with this, I will go through some of the cases which we have done, which will be of interest. So this is a case, you see the calcified lesion. Can anyone comment which modality of calcium modification tool can work here? I don't think besides Rota, anything can fit here. Hugely calcified LED lesion right from the ostium to the mid-LED. So you can't, you feel scared in negotiating this vessel, even with wire, rather than going with a cutting balloon, something like that. So nothing else but Rota works here. You see, after the initial run, which we caused through, there was a polishing run. And then finally, it was dilated with NC balloons. And this was stented, and we got through this result. So this was the final result. So, and this was not at all a case of bypass surgery. Can you see here the distal LED? There will be a huge atherectomy, and then again there will be you can't guarantee the treatment, the outcome. Sometimes you can get a lesion like this. You do a Rota, again you do a cutting balloon, you deploy a stent, but even after that, after cutting balloon Rota, your results are inadequate, and you have to go with IVL. So rotatripsy is needed in many cases, and it depends on what kind of lesions we are treating with. This is my final case. Can I appreciate here? Lesion is calcified, but is not very diffuse or kind of not much angulation, but there was only one angulation, and then finally we got a Rota burr proximal to lesion. So this is why it is important. We have to burr the proximal lesion also where there is a calcium, and then the Rota burr was stuck. We recrossed the LED, and then we dilated the balloon, and then finally the Rota burr was free, and we could do the procedure. So thank you so much for the patient hearing. I hope there will be a few questions. Thank you.